Hi, everybody out there. I hope you are enjoying some sunshine this morning. We're going to wait just about another minute to see if anybody else is going to join us and give some time for other attendees to sign in. So hope you're all doing well this morning, and we'll begin momentarily. I think we're kind of holding steady, so I'm going to go ahead and get started. Good morning. Thank you for joining us for this educational program. All participant lines have been muted to ensure the audio quality and provide a distraction-free learning environment. At the end of each presentation, we will allow for a short Q&A. You can use the comment section to send questions, and we will address as many questions as time allows. At the end of this program, we will send you an evaluation. We ask that you please provide us with feedback to ensure that we best serve our lupus community and provide engaging future programming. Each person that completes an evaluation will receive a $15 e-gift card to Panera. I'd like to take a moment to read a brief disclaimer. The Lupus Foundation of America, Greater Ohio Chapter does not give medical advice to patients regarding their lupus treatment. Your physician is the best source of information regarding the medical management of your lupus. This program is available for informational and educational purposes only. The content provided by other providers and/or professionals within the context of this program is not necessarily the opinion of the Lupus Foundation of America, Greater Ohio Chapter. So, with that being said, we will now begin the program. I'd like to welcome you all to the No Lupus 2022 Spring Virtual Summit. Thank you for joining us today. I know it's sunny out and you're probably eager to get out there, but we appreciate your attendance. My name is Adrienne Fernandez, and I've been dedicated to the mission of the Lupus Foundation of America, Greater Ohio Chapter for over a decade. I thank you for joining us this morning and for taking the time to learn more. I'd like to take a moment, Tina, if you want to flip through to the sponsors slide. Yep. I'd like to take a moment to thank our sponsors. Funding for this program has been made possible by an earmark from the state of Ohio and managed by the Ohio Department of Health, as well as the Ohio Commission on Minority Health. We would not be able to hold important programs like this without these pillar organizations. Thank you to each of them for their generosity and continued support. Slide 4. We are looking to reconnect in person in the near future. Projects are being carefully considered. We are hopeful that we can gather together soon. For the time being, we look to the bright side of digital programming. You're all used to that now. You can now learn from lupus experts and professionals from across the state of Ohio in the comfort of your own home. Today, our experts have created presentations specifically designed to help you better understand lupus and provide best practice for managing chronic illness. We have an excellent panel this morning. Our first speaker is Dr. David Blumenthal. His topic today will be Beyond Controlling the Lupus Activity, Additional Health Concerns that Lupus Patients Should Know. Dr. Blumenthal is a board-certified rheumatologist in the Division of Rheumatology at University Hospitals of Cleveland and assistant professor of medicine at Case Western Reserve University School of Medicine. Thank you, Dr. Blumenthal. We're going to go ahead and give you the floor. So here you go.
Thank you, Adrienne. Welcome, everyone. It's a pleasure to be here, and I thank the Greater Ohio Chapter of the Lupus Foundation for inviting me today. And one of the things we're going to be talking about is health concerns that everyone with lupus should know about that might not be specifically related to lupus. Next slide, please. And here's some of the things we're going to talk about. Health concerns related to lupus, lupus medications, and being on immunosuppression, medicine that makes your immune system weak. And the things we're going to specifically talk about include the metabolic syndrome, and I'll explain what that is in just a moment, osteoporosis and bone health, increased risk of infection, and cancer. Next slide, please. And one of the things I hope you'll get out of this discussion is a strategy to protect yourself from these things. And in order to reduce your risk, I really do recommend education, prevention, and early detection. Education, of course, is that you're knowledgeable about these things. And because you're knowledgeable about these things, you can have an intelligent discussion with your entire healthcare team about ways to protect yourself. You'll discuss with your healthcare team things that can be done to prevent future problems. And if it seems like a future problem is likely, what you can do through early detection to protect yourself and catch the problem in a very early stage before it becomes bad. Next slide, please. All right, let's talk for a moment about the metabolic syndrome. And for those who haven't heard of this, this is something that is going to be responsible for a lot of health problems in a lot of Americans today. And here's in the top 4 items on this slide, it tells us something about what the metabolic syndrome is. Folks who have the metabolic syndrome have often gained weight, and it's especially true about the metabolic syndrome that a lot of this weight gain is around the middle of the body. People with metabolic syndrome often have high blood pressure. They can have borderline diabetes or actual diabetes, and they have changes in their blood triglycerides and cholesterol that can lead to hardening of the arteries and fat and cholesterol deposits in those arteries. Triglycerides are a type of fat in the blood that can easily be detected on a blood test. And when we talk about cholesterol, we sometimes talk about bad cholesterol. That's the LDL cholesterol. And you would want that to be low. And we talk about good cholesterol, the HDL cholesterol, and you would want that to be high. But in people with metabolic syndrome, their cholesterol panel is just the opposite. Their bad LDL is high and their good HDL is low, and this leads to problems. And the problems that this can lead to are on the bottom of this slide. A decline in kidney function that can be so severe that the kidneys fail and it's necessary to go on dialysis. Atherosclerosis, which is fat and cholesterol buildup in the arteries that can lead to heart attacks and strokes. Hypertensive heart disease, which is a weakening of the heart because of long-standing high blood pressure that can eventually lead to heart failure, can occur. The liver can be affected, and people can get fatty liver disease that sometimes even leads to liver cirrhosis and liver failure. People often have high blood uric acid when they have the metabolic syndrome, and this can lead to gout. And it's very common with people with the metabolic syndrome to have obstructive sleep apnea, which might require them to wear a CPAP machine to help their breathing during the night. Now, the drivers of the bad stuff on the bottom of the slide is often the things on the top of the slide. So you would want to have a strategy for all of those things. Next slide, please. So why is it important to talk about the metabolic syndrome in the context of lupus? Well, people with lupus have some risk factors that can lead to the metabolic syndrome in their bodies. For example, if it was necessary to use prednisone in the treatment of your lupus, we all know that weight gain is part of the prednisone experience, and a gain of weight around the abdominal area in the center of the body is very much part of the prednisone experience. So some people have gotten quite a bit of weight gain from the prednisone that it was necessary to take for their lupus, and this could be one of the drivers of the metabolic syndrome. If the lupus has affected the kidneys, rising blood pressure is often part of that, and that's going to also promote the metabolic syndrome. Lupus itself doesn't generally cause diabetes, borderline or actual, but the prednisone can. Changes in blood triglycerides and cholesterol can also change just from having lupus. Lupus is an independent risk factor for developing fat and cholesterol deposits in the arteries, in addition to the usual risk factors like smoking and strong family history, age, and other things. So this can, in a person with lupus, the lupus factor is an additional risk factor for a decline in kidney function besides the risk factor of having the metabolic syndrome. And when the two are working together, this can be trouble for the kidneys. It can also be trouble for the arteries, which can lead to heart attacks and strokes. And it can be trouble for the blood pressure, which can affect the heart and the kidneys. So there's a lot of reasons why anyone with lupus would want to educate themselves about the metabolic syndrome, discuss with their medical team whether they're seeing any signs of this in themselves, and discuss strategies about what can be done. Next slide, please. Now, prednisone, as anyone with lupus would know, it is not a devil or an angel. It is sort of a mixture of both of those things at the same time. There are things that prednisone does to get early control of lupus when you're in the middle of, in the early stages of a flare, and that effect of prednisone is very good. But there's lots of things associated with prednisone that are bad. And you'll notice that everything in the slide is listed as a potential consequence of being on prednisone, which means that anybody who's needed to reach for prednisone to control their lupus needs to know a lot about the metabolic syndrome and to try to protect themselves so that these things don't happen. Next slide, please. So what can you do? Well, smoking is an independent risk factor for some of the badness that comes from the metabolic syndrome. So we would generally recommend that a person with lupus not smoke, and that they would also avoid secondhand smoke. Secondhand smoke can have bad effects on the body that are milder but similar to the effects of smoking yourself. It's also true that smoking is just plain bad for lupus. So that's another reason to avoid smoking if you're a lupus patient. Next, try to achieve and maintain a healthy body weight. That is very difficult in the setting of lupus. When people are having a lupus flare, they don't feel well, and they're not going to feel up to getting any kind of exercise when that's going on. They're also quite possibly going to be on prednisone, which is going to promote weight gain that's going to be very difficult to control. So we don't judge people who gain weight when they have lupus or when they're on prednisone, because in some circumstances these things are out of their control. But it is important to understand how weight gain can lead to the metabolic syndrome and to sit down with your healthcare team and discuss potential strategies. We do recommend that people get regular physical exercise, which can help keep multiple parts of the metabolic syndrome under control. Your medical team should be tracking your weight, your blood pressure, your blood sugar, your triglycerides, and your cholesterol, so you know where you are and whether you are slipping into the metabolic syndrome. If you catch this at an early stage, you might be able to intervene and do something about it. Make sure that if you're known to have abnormal blood pressure, high blood sugar, bad-looking cholesterol panel, that you get the proper treatment for that. And when the treatment is underway, you have to be sure to, quote, hit the target. And what do we mean by that? Well, for blood pressure, we would like your blood pressure to be about 120/80. And if you're on blood pressure medicines and your blood pressure is not coming down, you and your medical team are not done yet. You have to hit the target. You have to take blood pressure medicine that's giving you a blood pressure as close to normal as possible to get the benefits of blood pressure control. The same is true of blood sugar. The same is true of triglycerides and cholesterol. You want to make sure that you hit the target and reach your goals for all of those things. You can check the health of your coronary arteries with the help of your medical team. You could have a cardiac stress test. It might be done on a treadmill. It might be done another way. You could have a coronary calcium score by CT scan. So CT scans to obtain a coronary calcium score has become a very popular way to check somebody's coronary arteries and perhaps get some signs that they're in early trouble. And intervening at that point could potentially prevent a heart attack in the future. Just be aware that a CT scan does involve considerable exposure to radiation. So you do need to talk to your medical team whether getting your coronary CT calcium score is right for you. And let's remember the story with prednisone. It's a devil and an angel at the same time. It can save you and get quick control when you're in a bad flare, but too much use of prednisone can give you a lot of side effects, including the metabolic syndrome. So in general, we recommend that people and their medical team working together try to avoid both overuse and underuse of prednisone. Overuse is bad because of all the side effects. Underuse is also bad because it might mean your lupus might not be under optimal control. So work out with your medical team if you're on prednisone, whether you're on the right dose and whether it can possibly be reduced. Next slide, please. Now, the next thing I'd like to talk about is bone health. And there's a couple of things that come up in the context of lupus. If your bones are getting thin, your risk that your bone is going to break is going up. And there are two versions of thin bones, osteopenia, which is moderate bone loss, and osteoporosis, which is severe bone loss. And you can find out whether you have either of these things by having a bone density test done, which is similar to an x-ray and doesn't involve anybody poking you with needles. The risk factors for osteopenia and osteoporosis include early menopause, high doses and long duration of prednisone treatment. So prednisone can really cause a lot of calcium to leave your bones. And if it's been necessary to control your lupus with high doses of prednisone or with a long duration of prednisone, you might want to discuss with your medical team whether you should have a bone density test and see what kind of shape your bones are in. Now, another type of bone problem people can have is avascular necrosis, where the blood supply to the bone is not good, and this can damage the bone. This can occur in the hips, it can occur in the shoulders, it can occasionally occur in other places. The main thing that seems to cause this is high doses of prednisone. Even for a relatively brief time, a person could get avascular necrosis in their bones. There are factors related to lupus that can also lead to avascular necrosis. So if you're having a lot of pain in your hips or if you're having a lot of pain in your bones, sometimes it's a good idea to discuss this with your medical team, and they might want to get an x-ray to make sure that those bones are healthy and to make sure that there is no avascular necrosis. If avascular necrosis is present, your rheumatologist, in consultation with the orthopedic surgeons, will figure out what's the best thing to do. Next slide, please. So overall, in the realm of bone health, I'd recommend that people be knowledgeable about this, understand the things that can lead to your bones becoming thin, unhealthy, easy to fracture. And in order to prevent this, we generally recommend that you take a daily allowance of calcium and vitamin D, usually in pill form, because it's really hard to drink enough milk to get enough calcium every day. And there aren't that many dietary sources of vitamin D. Weight-bearing exercise is good for the bones. It doesn't need to be jogging. It can just be walking around. You and your medical team can check your vitamin D levels in the blood, and you can take supplements if it's low. A lot of people in the Great Lakes region, including most of the people who work for university hospitals and Cleveland Clinic, have low vitamin D because of where we all live. Today's a sunny day, at least for a few more hours, but the rest of the year it's not so sunny, and that's a risk factor for low vitamin D. Use prednisone with caution to try to keep your bones healthy. When it's necessary, it's necessary. But later on, when the lupus is under better control, try to bring the prednisone down. And have a bone density scan if you're at risk and you're curious to know what your bone density is. That way, you'll be armed with the facts about whether you're getting osteopenia or osteoporosis. Next slide, please. Now, what about immunosuppression? Medicines that make your immune system weak. Boy, has this come up for conversation in the last 2 years since we've had this coronavirus pandemic. As all lupus patients know, if you're on immunosuppression in the middle of a pandemic, you're nervous about vaccines, you're nervous about the virus itself, you're nervous about anything to do with immunosuppression because you don't want to get sick. So the risks of immunosuppression include the possibility that you could get an infection because your immune system is not so efficient at fighting germs. There are also risks of cancer that are associated with immunosuppression. Next slide, please. So how do you handle this? Well, I would suggest using the right immunosuppressive at the right dose for the right duration of time. So out there in the world of lupus patients, I would say there are people who have lupus that has been relatively mild. There's folks that have lupus that's been relatively medium in severity, and there are folks who have had lupus that is quite severe. And in general, our strategy would be mild medicines for the folks whose lupus is mild, medium medicines for the folks whose lupus is medium, strong medicines for the when the lupus is bad, because if what the lupus is doing to you is bad, you got to hit the lupus just as hard with something that is strong. But you have to understand the flip side of that is your immune system is going to be weaker than the people with mild lupus who are taking medicines that are mild. And this is the kind of thing you can discuss with your treatment team, whether you're on the right medicine at the right dose for the right duration. You can handle the issue of cancer associated with either the lupus itself or with the immunosuppression by getting age-appropriate cancer screening. And that's something that you can talk to with your rheumatologist or your primary care team. Things like mammograms would be an example of cancer screening to make sure that you're staying healthy even if you have an increased risk of cancer. You should call your doctor if you suspect an infection. We're a little quicker to put people on antibiotics than other people because we know your immune system is weak. It's easy to be checked for TB now because instead of poking your skin with the TB time test, now you can just do a blood test for TB, and this can be checked anytime you're going down to the blood drawing lab, and your rheumatology team probably will check this from time to time when it's appropriate. Blood tests can also be done for infection with the hepatitis B virus, the hepatitis C virus, and the HIV virus. And you can learn your status on all of those things just by going down to the blood drawing lab. Now, on the subject of vaccinations, there has been a lot of talk about this during the coronavirus pandemic. At first, we didn't have any vaccinations, and then we did. And across the United States, you'll notice that there are differences of thought about the value of vaccination and the potential risk of vaccination. In general, though, most rheumatologists are advising their lupus patients that the benefits of vaccination are almost always greater than the risks. It has to be decided on an individual basis, and I would suggest you discuss this with your rheumatologist, but you're going to find that most of the rheumatologists are recommending vaccinations as being low risk and very beneficial. You don't have to worry about how your body is going to handle a germ. If you have excellent immunity to that germ, it's less likely you're going to get sick. So the vaccinations that we have nowadays include the annual flu, vaccines against pneumococcus, often called the pneumonia vaccine, and you do need to get a booster if you've had the vaccine in the past. Make sure you maintain your immunity. People of a certain age especially can get vaccinated against herpes zoster, which is the chickenpox virus is really what it is. It's the same virus that causes shingles, and shingles is a very unpleasant thing, and we do have now vaccination for it. And we do recommend HPV, human papillovirus vaccination in young women, and for many young men, as a matter of fact. So this is something that usually comes up when people are under the care of a pediatrician or under the care of an OBGYN doctor. And between ages 9 and 26, people are eligible for the vaccine. And it's usually done at about age 11 or 12 in girls. But the vaccine is available up to age 45. And if somebody has never been vaccinated, HPV is a leading cause of cervical cancer. And the combination of immunosuppression and the HPV virus in the cervix is used to cause all sorts of problems for lupus patients and the health of their cervix and the possibility of cancer. And one of the ways to prevent this is to not have any HPV, and then you're not going to get HPV-associated cancers when you're on immunosuppression. Now, COVID-19 vaccination has been very controversial in some circles. It is absolutely not a perfect vaccine. People still can get coronavirus infection when they're fully vaccinated. But we do know that people who are fully vaccinated are much less likely to be hospitalized, and they are much less likely to get a fatal case of COVID. There are small risks associated for the vaccine, but in general, most rheumatologists do recommend that their patients be vaccinated against coronavirus, but that is something that each patient would want to discuss with their individual rheumatologist who knows their situation before making a decision. Next slide, please. So when we think about risks of cancer, family history is important. Some people have a lot of colon cancer in their families. Anybody who is like that might get a colonoscopy at an earlier age than other people, and they might get more frequent colonoscopies than other people do. There are also risks of cancer that are related to having an autoimmune disease. Having your immune system stimulated every day because you are an autoimmune disease patient can lead to cancers of the cells that cause lupus, things like leukemia and lymphoma. And there are additional risks related to being on immunosuppressive medicines, having a weak immune system because it's necessary to take medicines for lupus. So what do people do about this? Well, remember the general strategies we're going to be talking about today. Education, protection, education, prevention, and early detection is how you're going to manage your risk and protect yourself. Next slide, please. So here's some general recommendations for folks with lupus. To avoid skin cancer, avoid excessive sun exposure, use sunscreens and sun protective clothing. Folks with lupus are already doing this because they don't want their lupus to flare after excessive sun exposure. And it's especially important for people who are light-skinned to avoid sunburns because that can lead to skin cancers later in life. Avoid exposure to tobacco smoke because that's a risk factor for a variety of different cancers. Remember, choose the right immunosuppressive at the right dose for the right duration. Don't make your immune system weaker than it needs to be, and that could be a strategy to limit your risk of cancer. Get age-appropriate cancer screenings, like, for example, mammograms. And women especially should consider HPV vaccination. This can actually be a cancer prevention strategy. Fortunately, a lot of this is taking place in pediatricians' offices over the last 10 years or so, and hopefully the risk of cervical cancer will be going down. Next slide, please. So, health concerns related to lupus medications, and immunosuppression. Some of the things we've talked about today include the metabolic syndrome, osteoporosis, increased risks of infection, and risks of cancer. And how are you going to manage these risks? Through education, prevention, and early detection. So I think now we're going to open things up to a few questions. If I'm correct about this, we'll have a chance to discuss this in a little more detail. And I thank you for your attention today, and I hope you found this helpful.
Thank you, Dr. Blumenthal. It was a wealth of information, and I have to say, not only from a patient perspective, but listening to the entirety of your presentation, I feel bad for rheumatologists, because not only as a patient do we have to manage so much, but really you guys have to manage so much, and really always be on the lookout for all of these different things that can happen with lupus, because lupus affects every part of our bodies, really. So I know we have a lot of questions coming in. One of the first ones that came in was regarding coronary artery disease. Is the CT scan able, with or without contrast, to be able to look for coronary artery disease?
So there are different ways that CAT scans can be used to look at blood vessels in our body. The thing that is called a CT angiogram, they're really trying to put a contrast dye into the vessel, and they stare at it to see if it has any irregular flow of the contrast, or if it's or any narrowings that might indicate fat and cholesterol buildup. But in the coronary calcium score, they're trying to limit your exposure to radiation and try to do a limited CT. And one of the things that they're using here is at the same time the fat and cholesterol builds up in your arteries, calcium also builds up in your arteries, and calcium will show up on a CT without needing to inject you with any contrast, just like bones show up on an X-ray as being bright white. The calcium in your coronary artery shows up as bright white on the CAT scan in an artery that isn't supposed to have any whiteness. So they really are looking at calcification, and that's why it's called a coronary calcium score. And if you had contrast in your coronary arteries, they actually wouldn't be able to see the calcium very well because the contrast is white and the calcium is white. And you actually want to do it with no contrast and just look at to see if the arteries are getting calcified. It isn't a perfect test, but it's a pretty good test. And people who have very high coronary calcium scores, we are concerned about their arteries, and we might consult with a cardiologist or a vascular specialist to make sure that we're doing the right thing to slow that down.
Okay, that's interesting. Did not know that. And I can see somebody else is asking, at approximately what age should screening for coronary artery disease begin for a lupus patient?
I don't know that we've worked that out yet. In general, in the world of coronary artery disease, they judge it by how many risk factors you have. So outside of the world of lupus, your doctor will ask you, do heart attacks or strokes run in your family? How much exercise do you get? They'll sometimes ask you, what's the most strenuous thing you do? That's a sign that in your life, you might be doing your own stress test every day by deciding to walk up 2 flights of stairs to your office instead of taking the elevator. And if you're passing that, they might get a sense that you're passing your stress test and you're okay. They're also going to want to know about tobacco use and other risk factors such as diabetes or high blood pressure. They're going to want to know what your cholesterol numbers are. And as they look through all of those things, your heart attack risk score starts going up if you have a lot of those things. You would add to this lupus as an additional heart attack risk. So sometimes the only risk factor is the lupus itself, and there is not a single other risk factor. We would be less inclined to go looking for the coronary artery disease in a young person in that circumstance. But there are folks with lupus that have had heart attacks in their 30s, occasionally even in their 20s. It's usually a combination of lupus being a risk factor by itself, and sometimes they have 2 or 3 other risk factors. And if the treatment team never asked them about those things, they wouldn't know that they were actually at higher risk than anybody would have known. So I would say a lot of the younger folks can do stress tests. They're reasonably fit quite often. And if there was concern, probably a stress test would be done, because the coronary calcium score does involve exposure to radiation, and maybe they should avoid that. But if people are relatively sedentary and they're not sure that they can do it for whatever reason, if they're not sure they could do a stress test, there are other ways to do it, and the coronary calcium score is a good way to do it. But I really cannot give this group a general guideline that if you're at this age, you ought to go get it done. It really depends on your medical team's perception of your risk factors.
Okay, well, that definitely makes sense. Is there a difference of prescribed vitamin D versus over-the-counter?
There can be. There are, vitamin D is actually a molecule that under the heading of vitamin D, you got different vitamin Ds. For example, there is vitamin D2 and there is vitamin D3. There is 25-hydroxy vitamin D, and then there's 125-hydroxy vitamin D. And kidney doctors who do a lot of adjusting of people's vitamin D treatment, sometimes will use one and sometimes will use the other, even among the prescriptions. But for most people, you can get over-the-counter vitamin D. And you start off with the recommended daily allowance, which is 800 units a day. And then your vitamin D supplementation is adjusted because your doctor will send you for a vitamin D level from time to time. And if what you're doing isn't enough, your doctor will want you to take more. And that can be done either with over-the-counter vitamin D or something prescribed by your doctor. And that's something you and your doctor could do. But you can absolutely just get a big bottle of cheap vitamin D from your local discount house and save some money on that and get your vitamin D up to where it needs to be by doing that. But your doctor should check the blood from time to time. Vitamin D is what's called a fat-soluble vitamin, which means you can't overdose on it. Unlike other vitamins that leave your body rapidly if you stop taking them, vitamin D does not. And it can build up, and so you'd want to get a vitamin D level from time to time just to make sure you're doing this right.
Gotcha. Okay. Yeah, there are a lot of vitamin D supplements out there, so that's very helpful. I want to be cognizant of your time. Let's try to get a couple more questions in, but I know you have some other commitments today. So there is one asking about, is there a dead virus for shingles vaccine available for immunocompromised patients?
Yes. It used to be that the only vaccine we had was a live virus, and people on strong immunosuppression were advised to stay away from it because it could make them sick. Well, the pharmaceutical industry sees a market opportunity there, and they absolutely did develop a shingles vaccine that's very effective, and it's not a live virus. So that's the modern vaccine, and that's what most people get today.
Okay. Are there any other vitamins that would be helpful? Just general health, I suppose.
In general, if you eat a very varied diet with all the different food groups, there's a good chance you would not need vitamin supplementation for most things. But not everybody eats a diet like that for many different reasons. And if anybody who wanted to take a multivitamin every day, certainly could buy that and take it, and then you'd be certain you'd be up to snuff on everything. Vitamin D is kind of a separate issue because in this region we get so little sun. A lot of people are really low on vitamin D, especially people who are lactose intolerant and stay away from dairy products because it'll make them sick. So vitamin D is a separate issue. Blood levels would guide the treatment of that. Everything else, if you want to add a multivitamin to your daily regimen, you certainly can do that. But there is no specific sort of lupus-specific vitamin mix that I would necessarily recommend.
Okay, all right. This is an interesting question, and I think I know what this person's referring to. There is mention that it says mutant gene might be the cause of lupus. I think recently in the last week or two, there was some kind of variation on a gene that they identified. Do you have any knowledge of this recent discovery?
Well, let me give you the general lay of the land. There is something that is called monogenic lupus, and then there is something called polygenic lupus. Lupus runs quite strongly in families, as our audience absolutely knows, because they're aware of other people in their family, either close relatives or distant relatives who have lupus. And people have been looking for something you might call the gene for lupus. And in some people, they absolutely have a gene, a single gene, that is the cause of their lupus. These are often mutations in a protein in the blood that's part of the immune system, and this protein is called, these proteins are called complement proteins. So these people have one mutation in one gene, and it is the cause of their lupus. And mutations in complement genes is one of the things that can do this. Most people, though, have what's called polygenic lupus. They have mutations in multiple genes. And for a lot of people, it isn't going to be one gene. It's going to be a whole bunch of things. And therefore, when they find a new gene, it's often true that that gene is causing lupus in conjunction with 3 or 4 or 5 other genes, and it is not by itself the cause. But mutations in complement genes and a couple of other things can by themselves be the cause. At the moment, we are not doing genetic testing routinely for those things because we don't have a specific fix for that. But I suspect that genetic testing for lupus patients will get more sophisticated over time, and at some point in the future, people might be going to the geneticist to figure out exactly what their genetic risk is, especially if we have a remedy for that.
Okay. That whole field is fascinating, and it'll be interesting to see what happens as time goes on here. I want to ask one last question because I think it's important. It says, is there anything that men specifically should be doing or looking for with regards to lupus?
So, Adrian, as far as you can tell, does the question mean if a man is already known to have lupus, do they do anything different than everyone else?
I think so. Mm-hmm.
Yeah, so my advice for men with lupus, which is about 10% of the lupus patients, it is less common for men to get lupus. But when men get lupus, it's often rather bad lupus. And, you know, there's sort of a Mars and Venus thing here where women have been going to the doctor regularly since their teen years as part of a women's health program. And the Mars and Venus thing is that a lot of men don't go to the doctor and they're not really as engaged as women are sometimes in their health care. And my advice to men with lupus is you got to put the Mars thing aside when you have lupus. You could have rather severe lupus. And frequent doctor visits and strict attention to what medicines you should be on, educating yourself about the risks and benefits of all of these medicines, and working with your medical team to do this exactly right is really important in anybody with severe lupus. And that can include a lot of men. And because of the Mars and Venus thing, sometimes this isn't exactly their thing. I'm a member of that group myself, and every now and then I get the eye rolling from my wife because she thinks that I am an underutilizer of healthcare. And that is true of a lot of men. So any men out there, we need to follow the advice we are getting from the women in our lives, and get to the doctor and educate ourselves and do whatever we need to do to make sure our lupus is under control.
Great, great. Well, I know a lot of women that are watching this program are shaking their head yes, as I am. So it certainly rings true at my household. Dr. Blumenthal, thank you as always. It's been such a great amount of information and wonderful to hear from you, and thank you for participating today. We really appreciate it. I know you have to sign off early for these other commitments that you have today. We might have some extra questions that we'll be sending your way. So if we didn't get to everybody's questions, we will do our best to answer those at a later date. Thank you, Dr. Blumenthal. We appreciate it.
Thank you, and have a wonderful day, everybody.
All right, you too. Thanks.
Bye-bye.
We'll keep moving along here. We have Dr. Warren, who is a fan favorite around here. So we know he is a beloved member of the lupus community. And I just want to take kind of a brief moment to introduce Dr. Warren. His topic today will be lupus and gastroenterology. Dr. Warren is a board-certified rheumatologist in the Division of Rheumatology at University Hospitals of Cleveland and an assistant professor of medicine at Case Western Reserve University School of Medicine. Thank you, Dr. Warren. You may have the virtual floor. We're ready to hear from you.
Thank you. Thank you very much for inviting me. It's I always appreciate coming and always get a little nervous, but that's all right. We get when it's someone say if you don't get nervous about it, then you don't care about it as much. So this is, but I think that, I would like to appreciate the talk that we just had a few minutes ago. I also wanted to, my talk is going to be more limited to the gastrointestinal system, but it's an important system because that if you don't get your nutrition, then for a prolonged time or long enough time, then you'll cease to exist. And we want to try to describe some of the things that we can see with the gastrointestinal system that lupus may cause. Next slide, please. Now that we know that about 40% of patients will have some sort of gastrointestinal effect from the lupus over the course of their lifetime. It may be due to various things. One includes inflammation in the blood vessels like vasculitis, may have an effect because of medications that they're on, infections that just also was mentioned earlier. It may be, you can also have a problem directly related to the lupus itself, or the complications that lupus can cause, because lupus can also affect the muscles, it can affect your kidneys, it can affect the central nervous system. Next slide. Thank you. Now that I wanted to talk about, I want to like to start from the top and move my way down. And it turns out that the esophagus is probably the number one organ, part of the intestine that is affected by lupus. When the lupus is affecting your esophagus, you may have different symptoms that may occur, and you may get the pain behind the sternum, because your esophagus, and most people, it goes right behind your sternum in that direction. They may have heartburn, they may have regurgitation of foods that they have taken, they may have difficulty with swallowing those foods. Gastroesophageal reflux, and it may be due to some of these things may be due to malfunction of the motility of the esophagus. This can be related to side effects from infections like Candida infection, or basically a fungus infection, some viruses, herpes virus, CMV virus. In some studies they say 20%, other studies say 70% have difficulty with the motility of the esophagus. Now, the strange thing about this is that it doesn't seem to correlate with the activity of the lupus. The lupus may be quiescent in other places, but the esophagus may still have be involved, and it may have difficulties because of that. This seems to be having a fairly close association with the Raynaud's phenomenon, that generally people that have esophageal dysmotility may also have the fingers or toes that change color with cold exposure, and it also has an association with the RNP antibody. The cause of why this happens is not always clear, but it's suspected that it may be either from a vasculitis, or the interruption of the blood vessels, or the small blood vessel to the esophagus, or it may be due to a complex mediated thing in terms of antibodies attaching to different parts of the esophagus, and particularly the nervous part called Albart's plexus. We have the next slide, please. And this was just a picture I got off of the internet to try to demonstrate basically that dysmotility part of the esophagus. And it basically, look at the slide on the far left. It shows you that that bolus is starting from the top and going down. But if you look at that, where these contractions are, and about the midway of that picture, that it started at the wrong place. And so, and you look at the next slide next to it, you see that even though the constriction of the esophagus as it's trying to push things down is starting in the wrong place, so things are starting to fill up above it. And you can see that and the second screen, or second photo, is that the fluid is starting to collect above the esophagus. And then as you go through the third slide from the left, is that some of this food is starting to pass through, and you can see that it has the peristalsis, what it's called, or the contraction of the esophagus is kind of irregular, and it happening in multiple places rather than starting from the top and gradually moving its way down as way it should be in an organized fashion. Then the last slide, which is to the far right, it shows this esophagus is almost not doing very much at all, because that has the contractions are kind of like the lower 2/3 of the esophagus, and then the rest of the esophagus is just being filled up, whatever that contrast medium that they swallowed. We have the next slide, please. And then there's some other pictures on here that we're going to get to later, but I want to pay attention to that slide A, or that the A portion of this graph. And it's basically that blue arrow is showing that esophagus, that's where the esophagus is, but that esophagus wall is much thicker than what it should be. And if you look at that little tiny irregular shaped lumen in the middle of that dark spot, that's a lot smaller than it should be. And if you can imagine, if that were your esophagus at different parts of the different levels of the esophagus, you may have difficulty with either pain as it tries to push a bolus through to another slide or to another part of the esophagus that is not accepting it, or you may have regurgitation of the food that you're taking, so you eat something and you have to almost spit it back out, or you may get a chest pain. And the important thing about this, though, is that you may see patients that come in that complain about chest pain and thinking they're having a heart attack or some coronary artery type of problem, and it can be the esophagus, because the problem is that when you have chest pain in your mid to upper part of your chest, it can feel just like a heart attack. And then when they give nitroglycerin, sometimes nitroglycerin actually helps the pain from this too. So sometimes it can be very confusing. And then so it's an important thing to keep in mind also. The next slide, please. Gastric involvement is going as the esophagus that leads into your stomach. Yeah, sometimes you may have problems with the stomach too, and it can be from various things. One of those things is I wouldn't say common, but it's the peptic ulcer disease. And with peptic ulcer disease, a majority of cases asymptomatic. Matter of fact, they say about 51% is asymptomatic, and you don't know anything about it until you start to bleed. But many of them have epigastric pain. Some have pain. Epigastric pain even without meals. Some have epigastric pain when they eat something, especially if they eat spicy foods. They may have decreased appetite. They don't want to eat anything because it's uncomfortable to eat. They may have the gastrointestinal bleeding. They have a gastric outlet obstruction. These are the patients that are similar to that one we showed with the esophagus, where the stomach doesn't allow that food to empty. And it's generally because there's a blockage at the outlet of the stomach or in the antrum part of the stomach. It may have other complications, especially if it gets so dilated that from that obstruction, or that ulcer penetrates too deeply. You may get a fistula where you get a tract connecting one part of your stomach to another part of your intestine, or you may have a perforation where they actually have free fluid into flowing from your stomach into your abdomen. And sometimes this is associated with non-steroidal anti-inflammatory medications. You hardly ever see it from prednisone itself or by itself, but prednisone in combination with anti-inflammatory really increases the risk of having gastrointestinal ulcers or even gastritis. The Helicobacter pylori bacteria is also causes increased risk of ulcers, as well as increased risk of gastric cancers. May I have the next slide, please? This is just like a cartoon about that gastric outlet obstruction, and you can basically see that the stomach is basically enlarged, trying to push things through that narrow thing on the left. And we have the next slide. Now, this is a CT scan of a pediatric patient. And so that with this gastric outlet obstruction, and as you can see that on the right part of that stomach, or the body of that stomach, is huge. And then if you go toward the left part of that slide, you see the pylorus, where the body empties into the pylorus, and then the pylorus empties into the duodenum. And you see that area of that pylorus is much smaller than that area of the body of the stomach. And so they got all this stuff that stomach is trying to push through a little small narrow opening, and it's not being able to do it very well. I don't know if that slide will go up any on the. You can push it up a little bit. Otherwise, we can just go to the next slide. Thank you. Thank you. The small bowel and colon involvement. And this is kind of a strange kind of a thing, because it's a rare event, but sometimes it can be the very first sign of lupus, or when the lupus is first diagnosed, this may be part of their presenting feature. And because of this, you get the signs of what we call a mechanical obstruction type of thing. It's just that you're trying to push something through a place that it just won't go. And sometimes it's because of anatomic abnormalities, or it can be from neurogenic abnormality, as well as from a vascular standpoint. You don't get enough blood supply to the stomach or to the areas of the small intestine. When this happens, it generally occurs in patients that the lupus is very active, but it may occur, in lupus where it's not quite so active or maybe a surprise in some places and sometimes. It's generally associated with abdominal pain, abdominal distension, abdominal bloating. They look like they're holding onto a gas balloon. That the cause is unknown, but it's suspected it may be due to immune complex deposits either in the intestine or in the blood vessels. Next slide, please. And then this is that similar slide that we were looking at before, but this time we want to look at the B slide, or actually the B, C, and D on this. And it's basically, this is showing that the area of the intestine that is either interrupted in terms of its blood supply, or that is not allowing that blood to, food to pass through. And if you look at that in the slide B, you'll see that there's some things that looks like targets in there. And that's basically that the loops of intestine, that the intestinal wall is distended or stretched out, and that so you can see like a double layer. You see the outer wall of that intestine, and you see the inner wall of that intestine. And then you see that area right in the center of that target is the lumen, or the opening where the food is supposed to pass through. And this is actually can be quite complex. It can be also very dangerous, because you don't know if it's just because of air being filled in in the intestine, or that the intestine has a true blockage, or there's a poor blood supply to that intestine, that you can end up with areas of intestine that can even die. And then we're going to have the next slide, please. I want to come back to this in a minute. This is that, and then so sometimes we see that treatment of the intestinal obstructions is important, because that if it's due to the lupus itself, we may treat it one way, but if they have a true obstruction or a blockage in a blood vessel, we may treat it a different way. And this is that really, if you see that the patient has active lupus in other places, and we're really highly suspicious that it's the lupus that's causing this situation, and we don't see any signs of intestinal perforation, that would be dangerous to use this. We generally use high-dose steroids and sometimes even chemotherapy, particularly cyclophosphamide, but maybe also azathioprine. But cyclophosphamide sometimes we use because we can give it intravenously. We can also use other things that try to stimulate the intestinal activity, such as metoclopramide or some antibiotics like erythromycin. Then we also have some nutritional support, because these patients are generally not going to want to eat anything at all, and so that they can become dehydrated and very malnourished. So we have the next slide, please. This is one I wanted to get to. This is one that's actually can be very confusing as well, because this is pneumatosis intestinalis, which is generally a very benign manifestation of this intestinal problem with lupus, but this can also be due to obstruction as well. And if you see on this slide, there's actually multiple things going on. One is those at the top of the slide, you see that those bowel loops are very enlarged and full of gas, but you see that there's some layers in there of fluid in there. And generally, when you start seeing the air fluid layers like this, you start thinking about bowel obstruction, but this was actually a benign case. And if you look back at the poster aspect of that, or the bottom part of that slide, you see that those darker or grayish areas that's basically a fluid collection. So this actually also has ascites or fluid accumulating in the abdomen. But if you see this, especially if they complain about severe abdominal pain, this would be suspicious that they may have had a perforation and a bowel leak that caused that fluid collection. So sometimes these patients end up in surgery that they may not have necessarily needed, but you didn't know ahead of time. May I have the next slide, please? This is another kind of a manifestation of lupus that, and it's associated with after it goes on for a prolonged period of time, severe malnutrition. This is fortunately is a rare entity. It tends to occur more in young ladies with lupus, and generally lupus is much more severe. in this case, and it generally involves multiple organs. Because of this protein losing, basically they're losing a lot of protein from the intestine, and so if you don't have enough protein to hold the fluid within the blood vessels, they tend to the protein in the blood vessel tends to decrease, and then the fluid tends to leak out of those blood vessels into different areas of the body, including the abdomen. They may have the large edematous legs and arms. If you check their blood, they have low albumin, but when you check because a lot of times you expect to lose that protein in the kidney. When you do the test for the protein losing or wasting in the kidney, you find that their protein in the kidney may only be a slight or none at all. This is associated with at least about 50% of patients with severe diarrhea also. The treatment of protein-losing enteropathy is also nutritional support to try to get back that protein that they were losing. But we use a lot of steroids to treat this, and sometimes we even have to go to chemotherapy in order to minimize how much steroids that we're using. Because if you look back at the one slide that we talked about earlier, that the steroids, especially when they're in combination with anti-inflammatory medicines, can also increase the risk of intestinal perforations as well. We have the next slide, please. The liver involvement is, even though it's just outside of the main tube of the intestine, but the liver can also be affected by lupus. It can be affected in different ways, but it's fairly common, but it's generally not very severe, which is fortunate. But and it may be caused sometimes by the medicines that were used to either treat lupus or to treat some other condition. It's been associated with fatty liver. They can have viral hepatitis, especially the hepatitis B and hepatitis C, but also we've seen CMV and Epstein-Barr virus also. They may be due to a blockage in the blood vessel to either the vein or the artery that goes to or from the from the liver. There's a form called autonomic hepatitis. When I was in training, that used to be called lupoid hepatitis, and it's basically they have abnormal liver enzymes on the blood test, and then if you do liver biopsies, you can see that there's some abnormalities that may show up on the biopsy of the liver, and it may be due either to an autoimmune disorder of itself, that's a primary liver disease, or it may be a secondary to an autoimmune phenomenon related to the lupus itself. Let me have the next slide, please. That top left slide is actually supposed to be a normal liver, and it's where you see all of the little white spaces where it's the little sinusoids that allow the bile and stuff to pass through the liver. Then on the micrograph on the just below that on the left lower corner, there's also a normal liver, but it's showing you that the architecture of that liver with the portal vein, portal artery, and the bile ducts. And then if you look at this micrograph on the right-hand side, this is autoimmune hepatitis related to lupus. And you see there's an infiltration of a whole bunch of different inflammatory cells, mainly the mononuclear cells. But those are, if this is a higher micrograph, but if you look at it, you hardly see any of those sinusoids where they allow the bile to pass through. So you tend to have elevated liver enzymes because the bile is being blocked up and not really passing through the liver as well. And then you may have high liver enzymes on the basis that these cells in the liver are being destroyed and being leaked out into the bloodstream. We have the next slide, please. This picture is kind of a little blurry, but it's basically looking at that. I don't know what shape that is, like maybe a ham hock or something like that on the left upper corner, and it's basically that's the liver, but the liver has these kind of white patches, and this is basically a fatty liver or a fatty infiltration of the liver. Because if you look at that liver, it's actually if you look at it goes from about the left-hand side of the screen almost to the right-hand side of the screen. So this liver is a lot larger than it should be as well. We have the next slide, please. The pancreas may also be affected by the liver, and this is a situation that can cause very severe and intense abdominal pain. It unfortunately is not very common. It only occurs about 2 to 8% of people with lupus that's active. It generally doesn't happen that much in the lupus when it's not active on the basis of lupus itself. The onset is generally very persistent. That these patients don't want to have anything to eat and maybe not to drink as well. Anything that kind of forces that pancreas to have to release enzymes can cause severe pain. This pain tends to radiate from the epigastric region or right at the upper center of the abdomen, and generally radiates almost straight through to the back. And this is important because the other thing that tends to do is a condition called aortic dissection, in which case they have the aorta tends to split or to rupture. This pancreatic situation can give you a pain that seems to be very similar to that. So sometimes we may feel that patients may have an emergency aorta problem when it's really the pancreas. The laboratory generally shows elevated enzymes from the pancreas called amylase and lipase. And these can actually vary from pancreatitis can vary from, I would say, for a mild form, especially those who have something called chronic pancreatitis, or those which can be very severe in acute pancreatitis. Now, the problem with pancreatitis and lupus is not always clear as to what the cause for it was. One of the things that can happen is that you can get inflammation in the blood vessels that goes to the pancreas, or sometimes it may be some of the like the usual things that we tend to see with that cause for pancreatitis, like alcohol use or gallstones, abdominal injuries. But if you have that situation and then you have a lupus on top of it, they can be very complicated in terms of how to treat it. This is at the bottom of the slide. It looks like I will show you that sometimes some of the treatments that we use may contribute to this, and one of this happens to be steroids, like prednisone in particular. It can be a cause for the pancreatitis, but high dose and long-term use. And it maybe some of it's because of the atherosclerotic or the plaques that tend to form in those blood vessels that go through different parts of your body, but particularly the one that goes through the pancreas. But azathioprine has also been associated with pancreatitis. It seems to be rare, and many times if you have patients that have pancreatitis and they're taking azathioprine, sometimes we end up stopping that medicine or switching to a different medicine once the condition subsides in order to try to avoid this at least azathioprine being a contributor to this problem. We have the next slide, please. Now, this was a treatment of the acute pancreatitis. Is basically a supportive care as well. We basically try to put them on a bowel rest so that make them not eat for anything for a while, especially start staying away from fatty, greasy foods and high triglycerides to try to prevent that, because people that have high triglycerides have a higher incidence of pancreatitis also. You want to correct electrolyte abnormalities because these patients many times have low calcium levels. Generally, when you see a patient with pancreatitis with low calcium, that's generally a much more aggressive form of pancreatitis that can even lead to leakage of pancreatic fluid into the abdomen. And that pancreatic fluid is a very digestive or corrosive type fluid. It starts to eat up the surrounding tissues, so that either around the pancreas and the other structures nearby. You want and then if it's pancreatitis is due to the lupus itself, we actually use steroids to treat it, which is kind of counterintuitive, since we know that steroids sometimes can actually cause pancreatitis. But if we find that the pancreatitis, there seems to be no other cause for pancreatitis, and you have a patient with an active lupus, it may be that we need to treat that lupus in order to control the pancreatitis as well. If we have the next slide, please. This is a slide that basically between those two arrows, that's the pancreas. But if you notice that on the middle of the slide, the pancreas is kind of thin, and as it goes to the right-hand side of the slide, the body of the pancreas starts to enlarge. This is the inflamed part of the pancreas. Fortunately, this pancreas doesn't have a lot of calcium deposits. This doesn't show up on this picture. But generally, when you see calcium deposits, this is more of a chronic pancreatitis. And these are more prone to having recurrent attacks of pancreatitis. And so those have to be very careful about the types of food that they eat and substances that they drink. Let me have the next slide, please. Peritonitis and ascites. This is basically a fluid accumulation in the abdomen. Generally, this is if it comes on gradually, it's generally very painless, and patient may not even hardly even notice it. Just may think that they're gaining weight because they ate too much or something. But when it comes on rapidly or acutely, it's generally a very painful situation. And this is it's important for us to recognize, because these sometimes can be due to intestinal perforations, where you get bacteria and fecal material from the intestine leaking into the abdomen, and which can be quite dangerous and actually very lethal. But when the more mild cases are asymptomatic, a lot of times we really don't have to treat them at all, except for treating the lupus. But you want to be careful, because there are other causes for fluid accumulation in the abdomen. It's basically in patients that have congestive or right-sided heart failure, when fluid starts to accumulate on the right side of the heart, and they start to fill up their lungs, they start to fill up their legs, start to fill up their abdomen. You want to be careful that the patient doesn't have protein losing problems from the kidney and also from the intestine, because if we looked at one of the other slides earlier, that they can lose a lot of protein from the intestine as well. And then if you don't have that protein in your blood to hold the protein, hold the liquid in the blood vessel, it can leak out into other places, including the abdomen. The treatment for this is, if it requires any treatment, is basically steroids. We use the chloroquines, especially like hydroxychloroquine. We may use chemotherapies if it's severe enough, like azathioprine or cyclophosphamide. I tend to reserve those chemotherapeutics for either in cases that where you use steroids that we can't get the dose of steroids down, or those that are much more serious that are not responding completely to the prednisone or some type of steroid. May I have the next slide, please? This is a pediatric case of ascites. I just wanted to put that in there because it's not limited to adults. Children can also have this. May I have the next slide, please? Now, mesenteric vasculitis. Now, this is one of those conditions with the intestine that is actually it can be acutely serious. And this is, in other words, if the patient gets either this blocked blood vessel from inflammation of the blood vessel from lupus, or because of blood clots that are blocking up the arteries or veins to the intestine, it can be almost immediately dangerous and life-threatening. They tend to present in a very slow fashion or insidious fashion, and they tend to not want to eat very much. They have a pain with meals. It generally is a mid-abdominal type pain. They tend to have nausea. They may go to vomiting if it's severe enough. And interesting enough, they may have diarrhea, which is generally a paradoxical diarrhea. It's basically that since the solid food doesn't pass through, only the liquid tends to pass through. So it looks like they're having diarrhea when they're really constipated. The etiology is not always clear, but it seems to be either related to the antiphospholipid syndrome with a blockage in the blood vessel, or the inflammation in the blood vessel from either the lupus itself or from other infectious type etiologies. That sometimes we diagnose it by, which is suspected on X-ray. We see those dilated bile loops like we looked at on one of the other slides. CAT scans can also show these things, but the big thing you want to look for is to be sure that there's no blockage in the intestine from either a tumor or if it's high enough from an ulcer that either perforated or got so large that it narrowed the lumen of the intestine down. Let me have the next slide, please. And this is a classic kind of picture that I wanted to bring out, because I've shown this slide a few times, because this patient actually had just about the whole intestinal system affected by this lupus phenomenon. And if you look at slide C, it may be kind of hard to see, but you can see that there's like a streak of whiteness, almost like a comb. Maybe those afro picks that they used to use back in the day. If you look at that, if you see a picture like that, that's generally a very classic that this is a inflammation in the blood vessel cause for this this condition. There is no intestinal infarct that I can see on there, but you see those kind of almost like donuts or those targets in there, and then you see those that blood vessel streak that goes to that target. That's kind of almost like a mnemonic sign that this is intestinal vasculitis with a blood vessel to the mesentery that goes to the different parts of the intestine are being affected. This can be an absolute emergency type of thing to do something about this. And many times these patients may end up in surgery because of the perforations that can happen. May I have the next slide, please? And this is I may have the next slide after this. Is just talks about some of the treatment. It's basically if we can catch this early and it's due to the inflammation of the blood vessel and there's no blockage or perforation, we generally use bowel rescue to keep them from eating it or drinking anything. We have to give them intravenous nutrition. We use very high dose steroids if we can get away with it, and those that have no evidence of a bowel perforation or have a peritonitis or if you have evidence of bowel infarct, either by elevated lactic acid levels in the blood, or you see actually almost like wedge-shaped defects in the intestine that indicate that blood supply was interrupted for long enough for that part of the intestine to die. In those situations, surgery is probably about the only option they really have. This is a very dangerous situation. May we have the next slide, please? And those that we can catch early enough, but the steroids are not sufficient, you generally go to a chemotherapy type thing. And I like the cyclophosphamide for this, even though it's not my favorite drug anymore. But in this situation, it's probably one of the best. May I have the next slide, please? This is I think that must be the end of my slides here. So I wanted to open it up to questions, because I think that this was for me was interesting to see, because I've only seen a few cases of there's perforations due to this, but pneumatosis intestinalis with a large amount of gas in the intestine, that's actually not as uncommon as you might think.
It's interesting. First of all, thank you, Dr. Warren. So much information regarding gastroenterology and really the whole system. I think it's interesting to also comment that in our office, that is probably one of the most common calls we get is things having to do with the gastrointestinal system. So we have some questions flooding in, a lot of them. So we'll get started and try to get in as many as we can. The first one is gastroparesis a common disorder seen in lupus patients?
Actually, fortunately, that it's not, or maybe there's. I want to qualify this a little bit. I guess gastroparesis it may be seen, but generally it's very mild, and many times it can go actually unnoticed. But generally it's not. We generally don't see the severe cases in lupus, but there are cases that are reported. And it turns out that gastroparesis is actually I would say kind of difficult to treat, actually. And this is that depending on the severity. If it's mild, a lot of times we can use something called prokinetic type drugs. These are drugs that tend to stimulate the nervous system of the intestine, basically like metoclopramide, although you do have to be careful with that because some people develop neurologic problems from the metoclopramide for long use. Sometimes we use erythromycin, it's an antibiotic, but it's an irritant to the intestine, so it tends to cause the intestine to contract a lot. and that's why some people with erythromycin get all that nausea and the diarrhea from it. But in this situation, we actually use that as that side effect as a treatment. Then there's some other medicines that have prokinetic kind of activity, and that's misoprostol, which is actually used to treat gastrointestinal reflux or to try to prevent peptic ulcers from happening. But it works because it helps the intestine to produce prostaglandin E, which is generally one of the stimulants for the coating of the intestine to try to protect the intestine or the stomach from the acid. But it also tends to stimulate the intestine, and it stimulates a good portion of the intestine, not just the stomach. It also stimulates the small intestine as well. So we end up helping to get that intestine to move through. But you have to be careful in who you give it to. So in young ladies who may be considering pregnancy, you may not want to use that because it can stimulate some other things to move too. So it's like your uterus. So they may end up causing abortions or in that situation. So we do have to be careful. But it is an interesting phenomenon, and it does happen. Fortunately, we don't see as many severe cases of it. But when we do see gastroparesis, sometimes you also have to think about other causes, because probably diabetes is actually a much more common cause for gastroparesis. There are some neurologic problems. One is called Eden-Lambert syndrome, which is kind of similar to myasthenia gravis, but it has a little bit more higher association with gastroparesis.
Gotcha. So it kind of probably clues you in to look for some other things too, just to be on the safe side. Gotcha. We also have a person here who says, I didn't realize GERD could be lupus related. My primary care had me on Pepcid, that failed, went to omeprazole, and this person still gets a little bit of chest pains when they're eating. So I think the question really is omeprazole typically what treats GERD? Or do rheumatologists treat it a little bit differently?
It depends. When I get a case that's more difficult, I definitely have gastroenterology help, But we generally use those proton pump inhibitors, but sometimes we have to use proton pump inhibitors in combination with H2 receptor blockers too, because sometimes the proton pump inhibitor doesn't reduce enough of the acid secretion so that you can still get that acid reflux, because these proton pump inhibitors and even the H2 receptor blockers don't really treat GERD necessarily. They don't stop the reflux. They just reduce the amount of acid that comes back in the reflux, and that's basically what they're dealing with. And so that sometimes when we see GERD is not responsive and there's no other contraindications, I like to add misoprostol to it. But it actually helps to stimulate the intestine to empty out, so there'll be less regurgitant flow to go back up through the esophagus. That's sometimes a little trick that I use sometimes in those that don't respond sufficiently to the proton pump inhibitors with or without H2 receptor blockers.
Gotcha. So there's different options depending on how you respond. Got it. We also have somebody asking about gallbladder disease being affected by lupus. So does lupus cause gallbladder disease?
Well, I don't see gallbladder disease so much with lupus directly, but when I was in training, it said fat, fertile, and 40s. It seems like that there's some of the medicine that we use that treat the lupus, especially the steroids, and it tends to increase that truncal obesity, or they tend to increase the amount of cholesterol that starts to build up in the system, and so that they tend to get asymmetric or unbalanced amount of cholesterol or other triglycerides or even uric acid that tends to accumulate or bile acids that tend to accumulate in the gallbladder, and if it sits there long enough, it starts to crystallize. And then you start to crystallize, they get bigger and bigger, or get big enough to become sludge, and then even worse. So so it can be like an indirect side effect of lupus. But the other problem is that if you have gallbladder has a blood supply too, And if you interrupt that blood supply to the gastroepiploic blood vessel, it can not only affect the stomach, it also can affect the gallbladder and the liver as well, and the spleen.
Okay.
Circulatory.
Yeah, it's like dominoes.
Mhm.
Gotta watch for that. Okay, we have a lot of people asking about probiotics. Do you have a type of probiotic you recommend, or do you recommend probiotics at all?
Well, I do recommend probiotics, so that and I think that if you got those patients that have that gastrointestinal bloating, the ones that have that diarrhea, or that have the pneumatosis intestine, or that gas in the intestine, I've been used. I would say, well, maybe over the past I'll say maybe 2 years, I've been recommending it to some people, but I don't have a particular brand, and I should probably go look them up. But you have to be a little bit careful. But in some patients, those that have lactose intolerance, you may have to be careful about which probiotic to use, because some of those bacteria are grown in milk or dairy type products, and so that when you take that, you end up you're trying to get the probiotic to try to control this situation, but then you got the dairy that's stimulating the situation. So you got to be somewhat careful with that. The second thing about it is that they gotta be concerned about these ones that get these I guess you call them yogurts, so that have live cultures, I think they call it. Yeah, but I think by the time they pasteurize, they probably killed about all the bacteria that was there. So this is that there may only be a little bit left. So I think that you have to be careful. I think which ones you get, but I don't have a particular brand in mind.
Okay. Okay. Well, that actually kind of leads us into something else. Somebody's asking, do you see lupus patients that have food allergies to casein, so milk proteins?
Yeah, I'm not. I have a patient. I'm not going to take the credit because I didn't discover it. But this is that we have a patient that had sent to gastroenterology, and that they put them on the I guess you call it like a food restriction. That they look to see if they have. My slide keeps going out. We had a food restriction that so then they can kind of gradually reintroduce those foods. But one of the things that we also have to be careful about is that eosinophilic esophagitis, which I didn't mention it in here, but it's kind of an entity on its own. And that many times patients that have one autoimmune disease can also have another. And so that, but these are the ones that tend to have more of that food allergy type of a problem.
Okay. Okay. I think we have time for one more question. All the meds I take cause gastric problems for me, including ulcers in my esophagus. They feel that long-term use of these medications is going to continue to be a problem. She or he also says more and more medications are being done by infusion. Is this going to bypass my stomach, and will this be the future for lupus medications?
Or either that or subcutaneous, yeah. But I wanted to take a little step back and kind of look at these. I'm not sure if they had the Hill, go back to pylori and all that stuff, but I'm just saying that we're going to look back and then we'll see that there are some injectable non-steroidal anti-inflammatory medicines that kind of bypass a direct effect on of that medicine on your intestine, but it has an indirect effect. So this is that because once you get absorbed into the bloodstream, it can block that prostaglandin E2 with these non-steroidals, and then that can also reduce the amount of that gastric protection that your stomach has. So even though you didn't go by your mouth, it was going intravenously or even intramuscularly, it still had that same effect indirectly. So it missed the direct effect, but you still got the secondary effect of it once it gets into the bloodstream. And so that you can look at medicines like cyclophosphamide or nitrogen mustard, which most people get it intravenously, although it is some oral preparations for the cyclophosphamide, but they can be very corrosive too. So that we can a lot of our medicines have two edges. It's good on one side, and then they got another side that's not so good. And so that sometimes it's a balancing act. But I think that it seems like that the new medicines that are coming out now for treatment of lupus seem to be either intravenous or injectable, and it may be better for some people in that way, and especially if you think about those that may have the gastrointestinal malabsorption problems, or that have gastric outlet obstructions, or something that doesn't allow the to absorb the medicine very well from the intestine. I think that would be those patients. I think it's probably going to be probably the best choice.
Okay, well, great. I didn't know much about that, so that's good information to have there in case that's ever an issue. First of all, just want to say thank you so much, Dr. Warren. As always, a lot of great information. We're getting many people saying thank you for elaborating on the topic, and thank you for the information, that it was very helpful. So we really appreciate your time today. Thank you again for joining us. And I will do our best to forward some extra questions. If any have continued to come in or come in now, we'll go ahead and try to get those off to you in the future. But thank you.
No, thank you. I appreciate being invited. This is that I like that when people are happy to see you come, that's nice. But then they're happy to see you go, that's a problem. So thank you. Thank you very much.
That's the truth. Well, you're welcome. Thank you. So I'd also like to say thank you to our generous sponsors. Funding for this program, again, was made possible by an earmark from the state of Ohio and managed by the Ohio Department of Health, as well as the Ohio Commission on Minority Health. Again, we would not be able to have these programs without these pillar organizations, so we're so very grateful. This brings us to a close for our Lupus Summit, 2022 Spring Lupus Summit. Thank you everyone for joining us. We're tremendously grateful for our expert panel today that joined us to help create a path towards empowerment. Please remember to complete the evaluation that we send you. One will be sent to you an hour after this program. Once it's completed, it will prompt us to send you a $15 e-gift card for participating today. And please be sure to periodically check our lupus website, lupusgreaterohio.org, or sign up for our emails to keep up to date with information, services, and programming that we offer. You can also call 1-888-NO-LUPUS for more information or to connect with a local patient navigator. We are providing you with the most accurate information as it becomes available on lupus. Please be safe, continue to strive to find optimal health, and we hope to see you soon. Enjoy the sunshine today. Bye.
Bye.